for today, Dr. Tamu Davidson, Head of Chronic Diseases and Injuries at the Caribbean Public Health Agency. And so without any further ado, I will move on to our very first presentation, and I'll introduce our presenter at this time. So our first presenter is Professor Denise Eldemire Shearer. She will speak to us on the older adults and COVID-19, a Caribbean perspective. Professor Denise Eldemire Shearer is a medical doctor and a professor of public health and aging who has worked with the University of the West Indies for more than 35 years. She has had responsibility for developing postgraduate training in public health, of which research has been an important part, and has supervised many students at both the master's and PhD levels, and more recently, the Master in Gerontology. Professor Eldemire Shearer really is no stranger, as she is focused on aging as her main area of research, in which she has done extensive work. Currently, she is examining the responses needed to deal with an aging population, demographic, social, and health from several perspectives, and has also done work in the epidemiology of aging in Jamaica, intergenerational transfers, and economic contributions. Further, she's also involved in the medical care of older persons, and her focus is on combining the policy with the practice. Professor Denise Eldemire Shearer is no stranger and comes well equipped to speak to us on our first topic, looking at older adults and COVID-19, a Caribbean perspective. Thank you. We'll now hand over to Professor Eldemire Shearer.
Thank you very much, Dr. Davidson. And thank you for this opportunity, as you say, a subject that I'm fairly passionate about, and one that from my clinical practice has become more and more important with time. I didn't know I would be the first one, but wanted to just focus our attention. Even at the beginning of COVID-19, our attention was drawn to the importance of the NCDs. And the first study that came out of China began to tell us that older people in China at risk, this wasn't a study because this was 2018, that the persons that were sickest and those dying were in fact the older people. And nearly a fifth of the older population has at least 2 chronic diseases. And we were able to see when they started to look at COVID-19, and this has informed our work here in Jamaica. They started to look at the correlates, the older age, the being engaged in work, currently being a smoker, and obesity, which has begun to run quite heavily in our studies. And then our attention was focused in the USA, and again, the same issue of at least 1 chronic disease. So what was the position in the Caribbean as we began to focus in February, March on what was going to happen? And there is a Latin American Caribbean study, the SABE study, and again, 77% of the older people have at least 1 chronic disease, with 44% having at least 2. What was of interest was the 19% with a disability, and that was often related to both arthritis and to stroke. And we were sort of sensitized to what were the possible problems. Then the CDC started to help us in gathering our information, and their estimates, if you notice, are a little bit higher. 85% of older people with at least 1 chronic health condition. What is interesting about this, as you will see later, the CDC is actually nearer to the Jamaican findings than the others, not surprisingly. And this is somewhat higher than the national study that we had done now 9 years ago, which had 72%. So I tried to collect COVID Caribbean data. And I found that I was somewhat challenged to do that. I went on to the various websites, and the data is a bit sparse. However, our working relationship with the Ministry of Health here, and I must acknowledge the Ministry of Health in that respect. Those of us in the Mona Aging and Wellness Center were brought on board very quickly and very early, from as far back as February, as to advise on older people, let us call them their peculiarities, what was the impact of the geriatric giants, what was going to happen, or what was the prediction of what was going to happen. I was able to get some Trinidad and Tobago figures, and there's, you see the same pattern. So I have decided to focus on Jamaica in this presentation after some discussions with Dr. Davidson. However, before I actually look at Jamaica, let me point out that at the root of what I'm going to present is the impact of the stay-at-home order and the impact on NCDs. Stay-at-home orders, I was able to get information on, and they are pretty much across the larger islands of the Caribbean. I see a comment earlier which spoke to the fact that there are some countries with low numbers, and therefore they would not need a stay-at-home order. But Trinidad has a stay-at-home order, Barbados has one, the Bahamas has one, we have one, Antigua had one at one point. So that stay-at-home order has been quite common across the Caribbean. And it varies. Ours started off at 75 and over. As cases came about, it went down at one point to 65, went back up to 75, and is now back down at 70. So the Ministry of Health looks at it in relationship to what is happening with the cases. So this is the Jamaican situation. You will see that the cases are concentrated in Kingston and St. Andrew, the area in dark, which is the urban area. Most of the population are there. We went over 8,000 cases yesterday, and our earliest cases were in fact imported. I'm going to go here and then go back to the other one. This is the pattern of the disease as you have seen, as you can see. Now, we went along very well with all of the stay-at-home and the masking and the sanitizing until August. You will see a blip here, and this blip in week 15 and 16 is when we had an outbreak in one of our BPOs. And then at the beginning of August, we declared community spread. And you can see it on this one. The yellow starts towards the end of July. There was some yellow up here for April, and that's the spread from the case in the BPO. But then at the beginning of August, you begin to see the community spread. These are the yellow ones that we couldn't find any link to overseas travel, etc. We had opened up borders in terms of flights coming in of residents as far as June. And so there's quite a gap. It's not a 2 week, an incubation period. And then you can see what's happening, beginning to go down a little bit. But what's important to us and to this discussion right now is look at the 60 to 69. Look at the death rates in that 60 and over category. So we have cases, the active cases are actually lower in terms of numbers, but look at the deaths. And that has played a significant role. And you have a case fatality of 17.4% in the 80 and over. Can you imagine the highlights in the newspaper every day? 7 older people died yesterday. And this is what has driven concern, I would say fear, into our older people. We know that 80% of them have a chronic disease, as many as 40% 2 chronic diseases. And I will now show you the link between the two. So we did 2 studies coming out of the Mona Aging and Wellness Center, Dr. Douladell Tyndale Willie and Dr. Keon Donaldson Davis. And we found in July, we noticed the fall off in medical attention. So we did 2 studies of approximately 300 seniors each, so 600. One looked at health-related factors and the other at the impact of social isolation. And the findings were very interesting. 71% were very concerned about COVID-19 and 26% somewhat concerned. Older people were listening to the message and they were taking it seriously. 98% reported using masks, sanitizing, etc. And most believed that the restrictions were necessary. However, there was a 20% that we found that did not think they could be sustained. Interestingly enough, 24% of this population were working at the time of the restrictions. 20% lived alone. Look at the social distancing. 89% reported leaving home less, although the stay-at-home says you may leave once per day for the necessities of life. Necessities of life, we have found, was a little too vague and people needed to be more specific. 24% of them had actually stopped hugging at home. And we all know that social isolation is very important for avoiding geriatric giants. Also, they're not leaving home, and the physical activity, one of the fundamental tenets of chronic disease management, they're just not doing it. When we came to health, they were using public transportation, which people were told to avoid. 64% were using public facilities. And I'm going to skip over some of this because I see the time. These were the chronic diseases reported. I found it interesting that 9% were cancer survivors. This is the slide that I think from the chronic disease point is actually quite worrying. 60% had not sought medical care. This study was done in July and August. So for the first 8 months of the study, of the year, 60% of the population surveyed, 600 seniors, had not seen a doctor, despite 80% of them having a chronic disease. 18.1 actually missed appointments, and children and families stopped 9% from seeking care. So the NCDs and the management of NCDs is very concerning. So they're not doing any physical activity. The reduced mobility, 60% of a case series of 20 had reduced mobility, increased risk of falls. Nursing homes have reported an increase in the number of bedridden, and they've also reported an increase in mental deterioration. There is one case, and these are other COVID findings that my colleagues have shared with me. There's actually one case of dementia post-intensive care admission for 6 weeks. There are 5 cases of severe lung disease that were negative PCRs, but were positive for antigens, and 40% of those 5 were over 60, and one of the 2 older people did die. So the issue of long haulers and the issue of chronic lung disease post-COVID, that I want to raise that as a consideration. Since I do still have a minute or two, the reduced mobility is particularly worrying because one of the geriatric giants is in fact falls. We already have a problem of falls in the Caribbean, and there is data on that. And if people are just sitting at home, I have seen a couple of my patients who are now using walkers, not even walking sticks. And these are people that one of them was actually driving in February, but has not left her house. She's left her house 4 times in the 8 months. She even gets the pharmacy to deliver the prescriptions. So these are some of the issues with the NCDs. And if you go up here, you see that 6% went without their prescriptions. The 11% were their heart patients and the others that had missed clinic appointments and follow-ups. And the missed visits were primarily to the doctor. There's an additional in some of the focus group work that we've done as well with the seniors. The public sector and the private, both the, say, doctors and the staff are not touching them. So they're going to, those that are accessing healthcare are simply being handed a prescription when they get there. And as one lady said to me, I need my blood pressure checked. You have no idea what it is. Diet has come up in a number of other studies, especially a study done actually on children, and the issue of persons not being able, money is down. They have reported that they have less money, but more importantly, families have less money. An IDB study released last week said every second household has lost at least one income. Therefore, if we are considering chronic disease management as relying on physical activity, diet, and medications, I am very, very concerned as to what's going to happen next year, this time with our chronic diseases and the impact of the chronic diseases, the strokes, and those sort of things. And I will stop there.
Thank you, Professor Eldemire and Shearer, for a very riveting presentation, comprehensive presentation. Indeed, we can see the unintended consequences of the COVID-19 public health measures. And we have our work cut out for us to really address some of these issues. But we do have the evidence. And I think this is where it's a good starting point for us to build out on. Yes.
Dr. Davidson, one of the things that we're now going to do that we have this, because this is 6 months, we're coming up to 3 months. We're going to follow up with them and see what has happened.
Yes. With the reopening phase of addressing COVID-19. So I know the public health measures have changed over the past 3 months. So that will be very interesting finding. Thank you, Professor. We will have questions at the end. I just want to remind persons to put your questions in the Q&A section so that our presenters can answer those questions as we go along for the webinar today. You will see at the bottom of your panel Q&A. So if you've already put them in the chat, please try and put them in the question and answer section. Thank you. So our next presenter will present to us on looking at sickle cell and COVID-19. Sickle cell disease, another non-communicable disease that is characteristic of this region. So our presenter is Professor Jennifer Knight-Madden. She is the Director of Sickle Cell Unit and the Caribbean Institute for Health Research, the University of the West Indies. She has a PhD, which she obtained at the King's College London, where she examined pulmonary complications of sickle cell disease. She also has interest in newborn screening, asthma clinical trials, and implementation science. She has published several book chapters and more than 60 papers in peer-reviewed journals, including manuscripts and all about infections in sickle cell disease. She is active in the Sickle Cell Trust Jamaica and the National Sickle Cell Technical Working Group, the Caribbean Network of Researchers in Sickle Cell Disease and Thalassemia, and the Sick Kids Caribbean Initiative and the Sickle Cell Disease Ontology Project. It gives me great pleasure to introduce Professor Jennifer Knight-Madden, a dynamic but yet presenter who will share with us on sickle cell and COVID-19. Thank you.
Thank you very much, Dr. Davidson, and thank you for including me in this webinar. It's really exciting to be here. So today I'm going to speak with us about sickle cell disease and COVID-19. Thank you to Professor Eldemire Shearer for setting the ground in terms of Jamaica and the COVID situation. So I am going to head straight into the, let me just put that on presentation mode, straight into the meat of the matter. I'll do a very brief introduction to sickle cell disease, and then I'll speak about the epidemiology of sickle cell disease in the Caribbean. And then sickle cell disease, how does it affect the immune system? What infections have been important? What is happening globally with COVID-19? And a little look at what I think about sickle cell disease and COVID-19 vaccines. So sickle cell disease is actually a group of inherited blood cell disorders. What they have in common is that the hemoglobin in the red cell, the majority of it is hemoglobin S. hemoglobin S is produced instead of the usual A when you have a point mutation, which changes glutamic acid to valine in the beta chain. So is it a problem? It sure is. And this dude here, this mosquito, is perhaps one of the most dangerous animals on earth. But in the case of sickle cell disease, it is thought that in fact, having a sickle cell trait would be protective against dying from severe malaria. And so if you look on the panel to the left, you see the areas where you have a lot of malaria, where it's endemic. And if you look to the right, this is where sickle cell disease is most common. And of course, many of the genes in the Caribbean come from these areas. So with migration, slavery, and so on, you had the spread of sickle cell disease across the Americas and Europe and so on. But in fact, outside of Africa, the region with the highest incidence of sickle cell disease is actually the Caribbean. And so it is very important that we look at it here. Excuse me. So what do we know about sickle cell disease in the Caribbean? In Jamaica, where we have very good data, 10% have the trait and 5% have another trait that can put them at risk of having an affected child. So we end up having 1 in 150 births with a form of the disease. When we look at other islands and territories, it may not be as high as Jamaica, but it is still very significant, as high as 12.9% of adults in Tobago having a trait. And sickle cell disease affects everywhere that the blood goes, the entire body, and the immune system is no different. So you heard about the hyposplenism in sickle cell disease. In fact, most adults with SS disease no longer have a spleen, and even in children, it doesn't work very well. And in particular, the lymphopoietic elements in the white pulp that help to defend against encapsulated organisms don't work well. Furthermore, you have a problem with the alternative pathway of complement fixation, which also leads to defective opsonization. The leukocyte function may be abnormal, but I need to note here that the immune system in sickle cell disease is also turned up in some ways with high levels of inflammatory mediators, some of which can be produced by the neutrophils and the lymphocytes. Cell-mediated immunity may also be abnormal, but it's thought that immunoglobulins are not really a problem. So what does that matter? Well, children, particularly with sickle cell disease, have a huge increased risk of pneumococcal infection, maybe as much as 40 times. And this is why we use vaccines and penicillin prophylaxis. Haemophilus influenza B is also a problem, especially in places where vaccination is inadequate. And then Salmonella, osteomyelitis, E. coli, UTIs are also a problem. And although having the trait might protect you from dying of malaria, if you have the disease, you certainly can die from malaria. Now, the last two are of particular interest to us today. Dengue, because we have noted in Jamaica that the mortality was actually more common, higher in people with hemoglobin SC disease, which is a milder phenotype, and usually for most complications in sickle cell disease do better. Now, influenza, particularly when we had the H1N1, it was reported that people with sickle cell disease did worse. They had more severe disease, and it was often a cause of acute chest syndrome. So I'm going to talk a bit about COVID around the world. I will start with the Secure SCD registry, which is primarily American, but has some global influence. And then we look briefly at the French, Middle Eastern, UK, and Jamaican experience. So this is a map for the Secure Sickle Cell Disease Registry as of the 9th of October. And you can see it's primarily the US, but there are inputs from Europe, a bit from Africa, Canada, and Brazil. And yes, Guadeloupe, where they've had as many as 20 cases. Now, in this registry, they have 361 patients as of the 9th of October, which is the most up-to-date data available. And as you can see, there's a slight majority of women, but look at how young the people are. So there are very few people over 50. The mean age is 24.5. And as would be expected, most people self-report as Black or African American. Now, most of them have SS disease. That's the most common type. 2/3, with only 1 in 5 having SC. And we noticed that more than half of them were on hydroxyurea. Remember, these are mostly from developed countries such as the US and Europe. And 16% were on penicillin, probably younger children. And we see that many of them, 64%, have been recently hospitalized for pain. And as many as 30% have had acute chest syndrome. So pain and acute chest syndrome are the commonest ways that people with sickle cell disease present because of their sickle cell disease. What other comorbidities do they have? Of note, asthma is very common. So people with sickle cell disease often present wheezing, as much as 30% in children and 17% in adults. It's very concerning that as many as 11% of the children had issues with anxiety and depression. And the most common other more comorbidity in adults was cardiovascular disease. Now, when we look at how they present with COVID, look at this. 55% of them are actually presenting with painful crisis, and 27% with acute chest or pneumonia. In fact, 30% of them present with only pain, just pain. And another 16% have pain and pneumonia. So these are the usual presentations of sickle cell disease, but actually they're coming with COVID. So what treatments have they had? Azithromycin, heparin, a few with remdesivir, and several of them were hospitalized and some were in the ICU. Most had mild disease, a few, 3% were critical, and then the others were spread between moderate, severe, and just 13% asymptomatic in this group reported by physicians. And most of them had resolution of their symptoms, but 4% died, so 16 patients. So Julie Pina-Pinto, who is a PI on this project, published recently the experience in America between March and May. And she reported on 178 patients, mostly adults, mostly SS, a little bit more female than male. Severity profile, very similar. But look at this, 13 or 7% died, which is quite a bit above the WHO average of 2.9, mostly adults. And look at this, 40% hemoglobin SC or S beta plus. Remember, only about 20% of them had this kind of sickle cell disease. And then there were other risk factors which you would expect, which go along with severe disease and complications. So they decided that people with sickle cell disease are at high risk for severe disease and have a high case fatality rate. In France, which has the most sickle cell patients in Europe, they found something different. So they looked at 83 patients, most hospitalized, again, very young, median age 33.5. They had a history of acute chest, painful crisis, and almost half were on hydroxyurea. And how did they present? 54% with painful crisis, 28% with acute chest. They transfused about 37%, and of these 83 people, 17 were in ICU, and they were mostly greater than 45, which I guess in a way is elderly for people with sickle cell disease, and again, hemoglobin SC. So they only had 2 deaths, and they were both above 45 years of age, and they had SC. So they thought that overall, because most people with sickle cell disease in the world are young, then COVID-19 doesn't really carry an increased risk of morbidity or mortality because their young patients were not dying. In Bahrain, in the Middle East, they have a milder form of sickle cell disease. They screen about 5% of their population with a commensurate number of people with sickle cell disease, and they found 6 positives, or 1.6% of people with sickle cell disease. All were on hydroxyurea, and there was no difference in the rate of infection compared to the general population. 3 were asymptomatic, 1 was very mild, 2 had some symptoms, and only 1 needed oxygen. So they said, well, infection rate, clinical course, viral clearance, all the same, not different for sickle cell disease, not a worry. In the UK, they have a small study, only 10 patients, and 4 of them were actually PCR negative, mostly SS, almost all presented with pain. They were treated, oxygen, pain meds, antibiotics, anticoagulants, and they only had 1 death. So again, they're not that worried. In Jamaica, as far as we know, that we're aware, and thanks to Dr. Gabadon for providing this, we've seen 6 people, half children, half adults, half mild genotypes, half severe adult genotypes. But look at that. Both of those who died had comorbidities, so they had complications of their sickle cell otherwise. And remember, again, 2/3 have SS, 1/3 have a mild genotype, and yet 1 and 1. Small numbers yet. Hopefully we won't see very many because a lot of our patients are being seen virtually. We're encouraging them to physically distance and so on. In terms of vaccines, remember that people with sickle cell disease might respond differently. For pneumococcus, the pneumovax doesn't prevent all invasive pneumococcal disease, but it seems that it makes the disease milder. But we've even had patients who have had recurrent pneumococcal sepsis with the same actual serotype. So they respond differently. Nagant al. recently looked into it, and they found that 93% of previously immunized people with SCD actually had antibodies. They should have been protected. But when they looked more carefully, they found that there were low memory cells and both T and B cell after vaccination. So they may be at increased risk. So what are the take-home lessons? There are many theoretical reasons for people with sickle cell disease to be at risk of severe COVID-19. The largest study confirms the risk. Our data seems to confirm the risk, but some of the smaller studies did not. Some subpopulations are at higher risk, such as SC, those with chronic complications, and older ones. And the disease may manifest differently depending on, do you have HU and chronic transfusion? Are people crowded, or is there a different underlying phenotype? But what all of us as healthcare providers have to understand is that they present with the usual complications of sickle cell disease, like painful crisis and acute chest. So masks, hand hygiene, face hygiene, physical distancing, critical. And virtual care, whenever possible and appropriate, should be offered. But when face-to-face care is needed, it should be there. Thank you.
Thank you, Prof. Knight-Madden, for another excellent presentation, really giving us the key take-home messages around addressing sickle cell disease and COVID-19, the fact that the clinical presentation can vary. However, the clinical presentation is typical. The typical presentation for sickle cell disease may be someone who has COVID-19. So at this time, we're going to move on to our second presentation. And this presentation will look at children and COVID-19, a Caribbean perspective. Our second presenter is Dr. Tracy Evans-Gilbert. She's a consultant in pediatrics, tropical medicine, and public health at the Cornwall Regional Hospital in Jamaica. She's a senior associate lecturer in pediatrics in the Department of Child and Adolescent Health at the University of the West Indies, Kingston, Jamaica, and a preceptor for global health students at the West Virginia University. She pursued her training at the University of the West Indies, Johns Hopkins University, and the West Virginia University Global Health Program, and also pursued advanced training in vaccinology from the Les Pensieux Center for Global Health in France. Dr. Evans-Gilbert has co-authored close to 30 peer-reviewed articles in public health, clinical research in childhood infectious diseases, with an emphasis in HIV and arboviral diseases. She currently serves with the clinical working group for COVID-19 at the Ministry of Health in Jamaica, and is also a member of the expert advisory group for COVID-19 at CARPHA. She also is a part of the working group for the Measles Verification Commission for PAHO, and is a member of the Caribbean Immunization Technical Advisory Group. She's also a member of the American Society of Tropical Medicine and Hygiene and European Society for Pediatric Infectious Diseases. Another expert and someone well informed to share with you today, and I hand over now to Dr. Tracy Evans-Gilbert.
Thank you. I will now be presenting, I will now be looking at the children in, who are affected by COVID-19. Sorry, are you seeing my screen clearly? I'm not seeing my screen.
No, we're not seeing your slides.
Oh, okay, I think you're, you took me off. Okay, sorry, I'm putting it back up. Thank you. Okay, so we're going to be looking at children COVID-19 and a Caribbean perspective. You're seeing it now. Okay, great. Why am I not moving? Sorry. Oh, here we go. Sorry. All right, so I'm just going to give you a brief outline. I'm going to be looking at the impact of the lockdown measures in children, the epidemiology of COVID-19 infection, and look at some preliminary findings of the second wave, and then I'll summarize everything that I present today. So the first case of COVID-19 in the Caribbean region occurred in March in St. Martin, and a second in Dominican Republic coming from Europe. And many countries initiated stringent control measures to limit movement. And early timing of these controls impacted and contained the spread of COVID-19 across much of the Caribbean. Professor Ian Hambleton summarizes very nicely and said that within 14 weeks in the pandemic, about 20 CARICOM member states flattened after a short initial period of growth compared with 17 countries in the Central America and South America where outbreak growth continued. So these early border controls were effective among the Caribbean and small islands with a manageable number of physical entry points. However, there were 4 CARICOM members with land borders: Belize, Guyana, Haiti, and Suriname. And they would have had challenges in controlling their international movements as a result of that. In particular, Haiti, one of our colleagues in Haiti wrote this paper earlier this year, and she explained that because there's a shared border with Domrep, that border was porous. A lot of people could come through at different points, and as a result of that, 24,000 Haitian migrant workers fled Domrep and returned to Haiti. And even though they were very good at instituting those early measures, it only delayed the inevitable, but it couldn't stop the surge that occurred as a result of this influx of COVID-19 infected persons. The measures that were used to help to contain the lockdown of COVID-19 had some economic and social consequences that adversely affected child welfare in the Caribbean. It affected the children's nutrition, their immunization, there was loss of learning, there was increased vulnerability to child abuse, increased poverty, and mental health impacts on the children. UNICEF put together some of these secondary effects as it related to children and accumulated some data from different sources in addition to a survey sent out to different countries. What they found is that immunization wasn't affected for the most part in a lot of the countries, but was partially suspended in St. Lucia, Dominican Republic, and Haiti. And because of lack of monitoring in Jamaica, it impacted their immunization program. Overall, there was a 10% drop in immunization coverage in the region among the countries that reported. Dr. Eldemire Shearer had mentioned about nutrition, and it did impact on the children. There was a 75 to 100% fall in coverage for nutrition program for schools. And so this would impact children who were on a welfare program and needed food from schools. I'm just going to highlight some countries. Cuba, they were at one end of the spectrum where their health services were maintained and there was no impact on healthcare. And this was attributed to a strong primary care service that was linked with hospital-based services. They essentially, for their epidemiological surveillance, sent medical students and nurses from door to door asking if people had any respiratory symptoms. So they utilized their medical students and a wide array of persons to do some very strong epidemiological surveillance. So that's one end of the spectrum. The other end of the spectrum was in Dominican Republic, where half to 3/4 of the services related to children were affected. So their vaccinations, their growth and routine visits were impacted. In another study that looked at Haiti, they showed the percentage fall in vaccinations in the pentavalent, polio, and measles vaccine. And this has potential repercussions if vaccine preventable diseases such as diphtheria, measles, or polio should resurge, because this will burden the Haitian health system even more. As it relates to nutrition, they reported reduced admissions for malnutrition in the second quarter, but I don't know if this meant that they just didn't access the care. There's another study on families in Jamaica, and they highlighted some less than almost half the families experienced food shortages. Welfare students didn't have access to school feeding programs, and the combination of income loss to families and school closures had a mental health impact on the children. In addition to that, 40% were not getting any exercise. This was a review of 500 households, and there was loss of learning due to a lack of device or the internet. There was increase in violent discipline, changes in frequency of spanking and shouting occurred more often. And when we look in Trinidad, there was a vulnerable population of migrant children from Venezuela who were not able to access social services, or their parents, their job security was poor, and so a lockdown would further impact that vulnerable group. So now we're going to be looking a bit at the epidemiology of COVID-19 in the Caribbean children. There is currently a coalition of pediatricians across the Caribbean who are working together to look at the kids to see how they are impacted in the region. A structured questionnaire was sent out to the focal points in 16 islands, and they're asked a few questions about what surveillance methods were being used in their country, what were the surveillance sites, did they use telephone hotline or mobile units, and then to report on any cases that were reported by their ministries of health in the public press, in press briefings, or on their websites for their countries, and how many were hospitalized or died. In countries where there was not available data, publicly accessible data was used to supplement the survey. So these are a list of the 16 countries that were involved in the reporting across the region. 10 reported on the surveillance methods, and overall, if you look at the surveillance methods, most countries had a similar way of identifying patients, either by case notification, contact tracing, sentinel service, or cluster investigation. As it relates to surveillance sites, the primary sites were hospital and primary care non-sentinel sites, or ILI-SARI sites. Very few countries went into residential facilities or focused on vulnerable groups or looked at individuals in the community. All the countries that reported had a telephone hotline, and not very many had a mobile unit for surveillance. As it relates to the number of cases in the first wave, with the success of the lockdown measures, 4 islands or territories did not have any cases confirmed. 9 had less than 5, and there were 3 countries that had most of the cases in the Caribbean. These were in the Greater Antilles sub-region, in Jamaica, Cuba, and Haiti. This is a slide from the Trinidad and Tobago Ministry of Health, which showed the proportion of children under the age of 19 who were tested positive compared to the entire group. And their prevalence in children was under about 10%, and they had a slight male preponderance. As it relates to Cuba, they roughly had 10% positive among all cases when we looked between April and September. In Jamaica, there were 2 press releases related to Jamaican children, and one showed a 20%, almost a 20% proportion in the 0 to 19 age group, and 0 to 17, about 11%. That high percentage among the 0 to 19s was related to a call center outbreak. And call centers is usually young people that have come out of high school. So it's quite possible that this high prevalence was related to that call service outbreak and that cluster investigation. This is a slide which looks at Haitian children who were tested positive from May to September. And moving down along the cumulative cases, you see the numbers increasing with time, as with the total cases per month. The percentage of children that were positive ranged from about 5 to 6%. So we're seeing about 10% in Cuba, about 11 to 12% in Jamaica, and we're seeing about 6% in Haiti, where they are. If you can look at this carefully, their total cases by month far exceeded those that were in Cuba. I'm going to show you that. In Jamaica, they only had a small number. In Cuba in September, it was about 4,000 compared to about 8,000 in September of the same time. So they had a larger number of cumulative cases, and this number might represent the testing strategies, but about 6% were children. In the US, about 10% or 10 to 11% of all cases are children. And globally, there really has been only a small proportion confirmed cases of COVID-19. When we look across Europe and other countries, we see 1 to 8% of lab confirmed cases. And we don't know if this is as a result of limited testing for severe acute respiratory syndrome coronavirus, or it is that they actually do have less cases. What we know is that most children are asymptomatic, so they most likely may not have been tested. So the number is probably larger. So as it relates to morbidity, most childhood cases are mild and self-limiting, and there is a paucity of data regarding the clinical manifestations of hospitalized Caribbean children. Since the borders have reopened, we have counted 7 cases of multisystem inflammatory syndrome of COVID-19 in the region, and this is through the pediatric network. And there have been reports of increased COVID-19 related hospitalizations. Just to remind you what multisystem inflammatory syndrome, this is just a brief overview that the patient is diagnosed when they have fever, evidence of inflammation, they have multisystem organ involvement. There's no other reason why this is happening to them, and they have evidence of either antigen, antibody, or exposure to somebody with confirmed COVID-19. The other aspect of it is that if they present with Kawasaki or partial Kawasaki, multiple system inflammatory syndrome in children should be considered. WHO also has a similar case definition, but varies a little bit, but the same components are there, that you have to have inflammatory markers, you have to have multi-organ involvement, no other plausible reason why this inflammation is happening, and evidence of COVID-19 exposure or test. Now, very interestingly, in Cuba, they started looking at children who were affected and looking for cardiovascular problems. They found among a group of 30 odd children that 5 of them had cardiac issues, ranging from under 1 to most of them were over 10 years old. All the cases had contacts of a positive or suspected SARS patient. 20 of the children were asymptomatic, and if they were symptomatic, they had respiratory findings, rash, fever, headache, and vomiting. And 2 had multisystem inflammatory syndrome. These 2 are part of the 7 that we counted for the region. And what they did cardiovascular screening for children under 18 years old who had no previous chronic disease and had optimal nutritional status. And so 5 out of 36 of those were found to have cardiac involvement from echocardiogram evaluation. So when we asked among the network in terms of cases that we're seeing some very interesting presentations. We're seeing children that are testing positive who were just found out due to surveillance. So for example, there's a child who was going to surgery for a PR bleed for evaluation. They tested the child and it turned out to be COVID positive, and then the PR bleed resolved spontaneously. There's a child in hospital for diabetic ketoacidosis, and because the child is hospitalized, that particular hospital requires all hospitalizations to be swabbed, and it was found that that DKA child had COVID. Another little boy came with burns and fever, and because of the policy to swab, that child was found to be COVID positive. Febrile seizures and sickle cell patients. The sickle cell patients that we have seen who present with respiratory findings do not require oxygen and actually resolve quite quickly. Then there are a couple of cases of suspected dengue because they presented with fever, headache, myalgia, and joint pain, but when they did the COVID test, came back positive and the dengue test came back negative. As it relates to death, the majority of deaths occur in 2 countries, and we had a total of 14 since the beginning of the outbreak. There are different ways to calculate the risk of mortality, but the ones that exist are faulty. For example, the case fatality rate is dependent on confirmed cases in the denominator, and we know that we don't know all of the confirmed cases. We only know the cases that were tested, but we know that more people are likely positive. So that case fatality rate that will be calculated will probably be inaccurate. Similarly, the crude death rate, the denominator is the population, but not everybody in the population has COVID-19, and so the risk of mortality is not going to be accurate. The true risk of mortality is the infection mortality rate, where you know for sure the total number of cases in your denominator, and we won't know that until the end of the epidemic. So we still use these existing faulty calculations to look at the risk of mortality. And this here represents Haitian data, which showed us a breakdown of deaths for the 0 to 9 and 10 to 19 age group. And if you just look in the section that says cumulative deaths and case fatality rate, you see that the 0 to 9s have a higher case fatality rate than the 10 to 19 age group, ranging from 2 to 3.2 versus 0.6 to 1.2 in the 10 to 19 age group. So there's some suggestion that 0 to 9 group are more vulnerable than the older age group, and we don't know why. The same article that I quoted earlier gives us some insight into that. In the article, the author stated that the same factors that contribute to death from natural disasters make Haiti susceptible to a viral pandemic. So all the issues that were in Haiti regarding food insecurity and poverty and lack of water, sanitation, scarce health resources, and political division and inaccessible populations, all of these could adversely affect the outcome in a child, and it's not surprising why that particular country has the highest mortality rate based on what information we have here. When we compare the case fatality with other countries, Italy had 0, China had 0 from 0 to 9 and 0.2 compared to the higher numbers in Haiti. And in UK, 0 to 16 year case fatality rate was 0.3, and in the US, 0 to 0.16. Having said that, you cannot compare case fatality rates among countries because things are going to be different, their testing is going to be different. There are a lot of variables that will not allow you to make this comparison. So this table actually cannot be interpreted. I looked at the cumulative death rate, and what I've looked at is the denominator of the population of children compared with the deaths over time. And when you do compare Haiti with the remainder of the Italy and other European countries, we see that the crude death rate is pretty much comparable with other countries. So 14 in the entire Caribbean is, compared to the rest of the world, is actually within the normal for what's happening with children. So in summary, COVID-19 lockdown measures affected child welfare among Caribbean children. And early lockdown also helps in reducing the impact of COVID-19 in children in most islands who experience less than 5 cases. There are 3 islands that had the major burden of disease among children, and they had different circumstances: in Jamaica from a COVID-19 cluster and in Haiti from porous borders. We saw that mortality was highest in Haiti, where there is a susceptible, vulnerable population. And we also recognize that there are some unusual presentations that we're not going to know about unless we look for them and collate the information to see how that is happening. So there needs to be a heightened awareness and reporting, particularly of multisystem inflammatory syndrome. CARPHA and WHO does require you to report this. And when they collate that information, they can have a better understanding of this poorly understood disease. There is an urgent need for a robust evaluation of the direct and indirect impacts of COVID among children in the Caribbean. And there's more to be done to determine the extent of the nutritional impact, the prolonged screen time, the effect of remote learning, the extent of the child abuse, and the mental health in children are areas that really need to have further evaluation. I acknowledge my colleagues across the Caribbean who have been very wonderful in sharing their experiences, and thank you very much.
Thank you, Dr. Evans-Gilbert, for another comprehensive and excellent presentation. We will now go on to our next presentation. The next presenter will look at palliative care in COVID times, a Caribbean perspective. The next presenter is Dr. Natalie Sharp. She is a consultant physician at the Hope Institute Hospital in Kingston. She completed her graduate training in biochemistry at Vassar College in Poughkeepsie, New York, then worked as a research assistant at Columbia University for several years. She returned home to Jamaica in 2006 and started medical school at the University of the West Indies, then went on to do a residency in hematology and medical oncology. During her residency, she developed an interest in palliative care and did a certification course with Harvard Medical School and a clinical stint at the University of Colorado in Denver. One of Dr. Sharp's goals is the integration of quality palliative care into oncology care in Jamaica and providing access throughout all areas of the country. When she's not working, she spends most of her time chasing 3 energetic young boys. Another expert we have who is well placed to take us through this topic. Dr. Sharp, I'll now hand over to you. Thank you.
Hi, good evening, everyone. Are you hearing me?
Yes, we're hearing you loud and clear.
Thank you for inviting me to speak this evening on palliative care in the time of COVID-19. It's a very interesting time for us all. So thank you for asking me to come and speak. So I'm just going to start briefly with what is palliative care. Just a reminder that palliative care is a specialty that aims to relieve suffering in patients with advanced diseases. We try to provide relief of physical distress, relief of psychosocial distress, home care support, as well as try to help patients identify their goals of care and with advanced care planning. So how can COVID-19 affect our palliative care patients? Well, it affects their clinic visits. It affects their access to medications, access to blood products if needed, their home safety and their home care, and it also affects their connection to family and friends. How have the clinic visits changed? And I mean, I imagine it's changed very similarly for everybody else and for all clinics all over. There's screening of patients and family members before entering. There's restrictions on the number of people who can accompany or visit a patient. the usual mask and hand sanitization expectations. There's distancing between patients in waiting areas. And this is actually a very interesting point because many of our patients, they're used to seeing the same patients with them, whenever they come to their appointment. So a lot of them are on the same schedule. So, every month you come and you expect to see this other person in the waiting area. And so it's an informal kind of support for them to have the other patients there with them. But now they have to maintain distance, and they also may not even see that person because of, changes to timing, etc. And then also splitting of medical teams, in order to try and protect our physicians means that a patient may not see their usual doctor. In terms of alterations to general care due to COVID-19, we've had to put in place many things to adjust the care. Sometimes routine follow-up visits for patients who are not on any active treatment may have to be postponed. We may do remote check-in via telephone, via email, or some other messaging type service. We advocate that the patient can manage to do that home collection of blood samples if possible. Ensuring sufficient medications by sending prescriptions directly to the pharmacy for delivery, or we encourage trying to pick up medications curbside if it's available close by. And then also alterations to treatment plan. For example, if it's a patient who part of their palliative care calls for chemotherapy, we may change their regimen to something where they don't have to come in every week. We may change it to something where they can come every 3 weeks. Or then we may change them from intravenous chemotherapy to something oral so that they don't have to come actually to the hospital as often. Or, planning something such as radiotherapy for pain, we may try to give it in, a fewer number of doses or fractions as opposed to having multiple fractions like we usually would. So adapting palliative care principles. So, even though we would like to do all the things that we spoke about, care must continue to prioritize the relief of severe distress and management of severe acute complications of cancer. Many symptom control issues can be managed by telephone consultations. However, not everything can be. And then whenever possible, we try to advocate strongly for home care services for the patients, anybody with anticipated high needs. So what are the new challenges to hospital care in time of COVID-19 for the palliative patients? Well, limited hospital bed space. Of course, as with other hospitals, many of the beds and the wards are being taken up for isolation stays or, just as a regular SARI or RLI ward. And for example, in our hospital, we are the only palliative care hospital in Jamaica. And, for our ill patients, we have a ward that consists of only 12 beds. However, for 12 female beds, the female ward has 12 female beds. But however, now because of COVID-19, we can only use 6 of those beds in order to maintain social distancing. So it's difficult because, even before COVID times, we had a long waiting list of patients to be admitted, patients with high needs. And now that we have fewer beds, we still have the same number of patients that need acute care. There's limited hospital visitation. The regulation now at the government hospitals and at most of the hospitals in Jamaica is that you're only allowed 1 visitor per day. And during the visitation time, I've actually seen hospitals where you're only allowed 1 visitor for your entire hospital stay. So it has to be the same person come every day. And so in patients who have advanced cancer and advanced diseases and who oftentimes may be dying, you kind of want your family around you. You want that social support. And unfortunately, these strict visitation rules, don't allow for that. We also have physicians being reassigned to other areas of responsibility. Because of the high burden of work due to the pandemic, we don't have all the physicians available that we used to. And in addition, physicians themselves have also been exposed and are also getting sick. So we have to consider that as well. And we have limited staffing. And then also there's patient fear of the unknown going into a hospital. You don't know what the outcomes are, and you don't know if you're going to a hospital to expose yourself to COVID-19. People are always afraid of what's happening and what's going on around them. So in terms of admission to hospital and inpatient management, we're trying to prioritize more critical issues. So these are some of the things that we would think this person definitely we should try to admit this patient for. Spinal cord compression, gastrointestinal obstruction, intractable vomiting, severe dyspnea, severe anemia, symptomatic effusions, superior vena cava obstruction, symptomatic brain metastases, and uncontrolled pain that has failed outpatient management. you know, as much as possible, I try to advocate for home care for very advanced patients at this time. And so how do we go about optimizing that? The tips that I would recommend to help with that is at the earliest opportunity, identify patient goals of care and preferences for treatment. Talk to the patients early on, talk to the patient's relatives if you can about, what are we trying to achieve? What are the things that, if this were to happen, what would you like to do? If you have, another urinary tract infection, this is your sixth one in, less than 2 months, do you want to go back into hospital again for that, knowing all the problems associated with going to the hospital? So you have to identify what the goals of care are, right? And how a patient would prefer to be treated. Try and identify a pharmacy to collect medication. Try and develop a relationship with a pharmacist so that it can make things easier to access medication. We also try to train family members to provide certain parts of care in order to avoid unnecessary visits by medical personnel. For example, patients who need regular dressing, or patients who need certain types of subcutaneous injections, for example, filgrastim to boost your white cell count, etc. We try to, as much as possible, to have our family members learn how to do this so that the patient doesn't have to go to the health center, doesn't have to go out to get these things done. And then I also recommend maintaining open lines of communication. Our patients know that they're free to call us at Hope Institute at any point in time, and they can speak to a doctor or nurse. Their relatives can as well, in order to get advice about care before any decisions are made about what to do. I also advocate that patients identify a nearby general practitioner or family doctor who would be willing to step in and consult with us at the hospital if needs be, or as necessary. Because oftentimes, we as the physicians or our nurses or somebody's not able to get there, but if you have a family doctor who you trust who is nearby, then that could be the person who comes to see to liaise with care. Some barriers to optimal home care. Here in Jamaica, home care is not covered by the government healthcare program. And so unfortunately, things like home nurses, are not covered, home health aides. Unfortunately, patients would have to pay out of pocket for that. There's limited access to opioids. Opioids generally are only available in Kingston and St. Andrew, and then in Montego Bay. So on either side of the island, in several parishes in the middle of the island, there are no pharmacies that dispense opioids. So some patients will have to travel for hours to collect their pain medication. And then the legislation surrounding dispensation of opioids. The pharmacists are only allowed to dispense 2 weeks of opioids at a time. So, can you imagine having to, in this time, travel every 2 weeks to get your medication, your pain medication? It makes things difficult for the patient. There's poor social support in some sectors of society. And it's difficult for people to manage because oftentimes we hear, well, I can't take care of this patient because I have to go to work. And we can't leave her home alone. So unfortunately, our society, things are difficult throughout. And then there's a lot of resistance to the belief that care can occur at home. Sometimes relatives are just find it hard to believe that they can manage the patients at home. You give better care here in the hospital. I'm not able to do what you do at home. And so it's important to walk them through and to try and empower them to know that they can provide the care that the patient needs, and that, we as the medical team are, close enough to give advice and to provide support, but it is something that can be managed at home. I also recommend a lot of caregiver support because in addition to the burden of caring for someone with cancer, it's, on top of this, the whole COVID-19 pandemic makes things even more difficult. So the tips I offer to the caregivers are maintain your social support as much as possible, try and avoid information overload, trust reputable sources for your information, take a break sometimes from news or social media, deep breathing, stretching, or meditation can be helpful. Try to maintain healthy eating, exercise, and sleep routines, and take time for yourself to unwind. So one more thing I just wanted to note, wrapping up with regards to palliative care. When I was, trying to put together this presentation, if I Google palliative care and COVID-19, what comes up most is that, so in the Caribbean, well, in Jamaica, and I suspect most of the Caribbean as well, so when you think about palliative care, you think only about cancer care. But, of note, in much larger countries, palliative care is provided generally by family care physicians or internists, and it's provided to anyone with any kind of advanced disease, such as people with heart failure, people with respiratory illnesses. So when you look up palliative care and COVID-19, what you find is a lot of information about palliative care physicians being involved in the care of patients with advanced COVID-19. So being involved with their symptom management, their end-of-life issues, and then their support related to their isolation, that they have at the end of life or even when they're being treated for those diseases. Which I thought was very interesting because it's a direct comparison to how COVID-19 is managed care and the role of palliative care in the curriculum. So just some take-home points regarding palliative care. Just expect changes, be flexible, product allocations. As always, we should all be doing practice setting the curve. Be prepared. Be prepared in advance helps you to help better manage the things that can happen. Keep open lines of communication with the healthcare team. I advise my physicians to empower family members to assist with care. And then just remember that palliative care philosophies are applicable to all patients with advanced disease, which now includes COVID-19. Thank you.
Thank you, Dr. Sharp, for another excellent presentation and reminding us that palliative care extends to many other conditions outside of just cancer care, but also COVID-19 and other conditions. So thank you again for your presentation. I'll now go on to our next presenter, who will present to us looking at stigmatization of COVID-19. And Dr. Cheryl Jones is also another presenter who is no stranger to the region. She received her training in medical sociology from Howard University in Washington, D.C. She is also an educator with a plethora of experience in research focused on behavioral aspects of public health, as well as in curriculum development and implementation. Dr. Jones has developed curriculum and designed training modules for private institutions, including United States university system and for multinational corporations. Her experience in higher education include research, instructor, and chair of culminating experience, areas such as Masters of the Public Health Program at Morehouse School of Medicine. She's been an adjunct professor in health services administration and also guest lecturer at various colleges in the United States and the Caribbean. Currently, she serves as a behavioral scientist for the Caribbean Public Health Agency. And in this role, Dr. Jones provides technical support to CARPHA member states. Her expertise assists in the development and implementation of regional and national approaches to identify, enhance, and implement evidence-based public health interventions and innovative initiatives that seek to reduce the impact of HIV/AIDS, NCDs, vector-borne diseases, and public health emergencies throughout the Caribbean. Dr. Jones obtained her Bachelor of Business Administration in Business Information Systems, a Master's in Business Administration with concentration in Finance and Decision Sciences, a Master's in Public Health in International Health, and a PhD in Sociology. Her dissertation completed at the Howard University was entitled The Impact of Social, Political, and Economic Factors on the Midwifery Model of Care in Eastern United States and Port Antonio, Jamaica. Without any further ado, Dr. Jones comes with a lot of experience here and is well placed to present to us on the stigmatization of COVID-19. So I'm handing over now to Dr. Jones. Thank you.
Okay, so it's check-in on Friday of December the 4th.
Hi, good evening. Thank you so much, Dr. Davidson. Are you all hearing me okay?
Yes, we're hearing you fine. Yes.
Okay, good.
So you want to be on presenter mode?
Can you see my screen?
Yes, we can. I'm seeing your next slides with notes. So perhaps you want to go to presenter mode.
So it says it's in presenter mode.
Okay, okay.
Perhaps
Perhaps you would end the slideshow and then go back.
Yeah, I do apologize. My laptop actually had some issues just now. All right, let me start over.
So go back to slideshow and then present alone.
Yes?
Yes.
Okay,
Yes.
so say again? I
Yes,
can
go
go.
ahead, please. Yes.
Okay. Today I'm going to talk briefly about, I say briefly because of course stigma and the stigmatization, stigma and discrimination can be talked about for quite a bit of time. So today I'm going to kind of give a very brief highlight of what we're talking about. We're talking about stigma that leads to discrimination with respect to NCDs and COVID-19. I'm going to then share with you an overview of some evidence-based recommendations for addressing stigma and discrimination in various settings. So as we know, stigma has been very well documented. It's a barrier to health-seeking behavior across a number of different health conditions and health situations. It enables varieties of discrimination that both deny individuals as well as full groups access to adequate health care, and reduces positive health-seeking behaviors, and influences population health outcomes by undermining processes, impeding processes for accessing care, impacting negatively on social relationships, impacting negatively on resources that are available, and increasing various levels of psychological issues and stress, which ultimately can result in poor health or poor health outcomes. So the root, when we look at stigma, the root of stigma and discrimination is actually basically a human concept, or a part of our human reality. As humans, we're constantly evaluating our ever-changing environment. And so I'm taking this down to a very, very basic level because I think it's very important that we step back and really understand that stigma and discrimination is something that has been going on for a very long time. What happens with humans? We evaluate our environments. We evaluate our environments for positive reasons, but it also results in us looking at or developing particular views on different people, on different animals. So it's not just based on humans. So as we've evolved, we've looked at humans and creatures to identify things like, what are we afraid of? Why should we be afraid of this person? Why should we be afraid of this thing? And how should we respond to protect what is ours? Or how should we respond in general? Maybe it's not a protection. How should we respond to even protect that person or that thing? We look at, we evaluate others for competition purposes to identify what type of burden we might incur in an interaction or taking on a particular relationship. In addition, we also evaluate others for relationships, for partners, whether it's a partner as a friend, a business partner, a work associate, or a personal partner, or leading to a family in intimate settings. So we've evaluated as humans others forever, basically, and it's the way we understand our world. However, unfortunately, sometimes it results in stigmas. Different types of stigmas result from the way we use the information that we gather in these evaluations. So there's a perceived stigma, And that's a perceived stigma results in negative attitudes. A lot of times, these negative attitudes include the fear of discrimination, feelings of shame that may be brought to the attention of an individual or a group. So the perceived stigma is usually something based on an individual and the way they look at themselves and others. Internalized stigma is an acceptance of those negative beliefs, views, and feelings. And an enacted stigma is a negative and a discriminatory attitude that will result in an actual exclusion of a person or a group of people from something, whether it be from something, I'll just leave it at that. Then you have the layered stigmas, where you have stigma that's based on several or many different factors. And then of course you have the institutionalized or structural stigma, in which these beliefs or attitudes are implemented based on policies and or procedures. And sometimes the institutional or structural stigma is not an intentional, may be done unintentionally. So what I'm going to talk about is how indeed this pandemic has resulted in increased fear and uncertainty, has resulted in the development of xenophobias that are aimed at people who may have been thought to have brought COVID-19 into a country, who maybe have thought to be the reason for the existence or an increased risk of spreading COVID-19. So you'd have persons who would be essential workers, specifically in healthcare, people who have recovered from from COVID-19, or people who actually are currently have COVID-19. And then other persons that will face stigma and discrimination would also be persons who already have a stigma or discrimination associated with them or potentially associated with them. And as I was saying, as I mentioned earlier, as humans, we have a tendency to look at everything and look for whether it's a weakness or whether it's a perceived threat. And we have a tendency to look at various groups. So you would know that there is stigma and discrimination that's always been associated with HIV/AIDS. And there's always been a fight to address the stigma and discrimination so that we can ensure that persons who have HIV/AIDS or at increased risk of HIV/AIDS have adequate access to the resources that they need to survive. The same things happen with people who have NCDs. The same thing happens with people who are potentially obese or considered overweight. Oftentimes there'll be a set of stigma and or discrimination associated with them. So that is why, or with us, because that is why, not to mention gender, I meant to also mention that gender is a very critical factor. Gender and sexual minority groups are very critical factors when it comes to stigma and discrimination. So with COVID-19, you have somewhat of an intersection of potential stigma and discrimination that we as healthcare providers and in different settings, we have to make sure that we put interventions in place to try to reduce the amount of stigma and discrimination that could be associated with COVID-19 and the intersection of the other areas in which stigma and discrimination exist. So what has happened with the pandemic, we have been seeing an increase in violence and harassment within the context of COVID-19, coupled with gender, coupled with gender and different gender roles, coupled with other health conditions. And what has resulted is a negative impact on the delivery of the essential health services that are needed to prevent the spread of COVID-19. And I believe it was Dr. Eldemire Shearer in her presentation that actually brought to the forefront the data that looks at the number of elderly that have not gone to access care because of the perception or the increased risk associated with COVID-19. So this pandemic, and also the unintentional possible stigmatization of people, can result in their inability to access care, or the inability to comfortably access care. So what can we do? What needs to be done? One of the things that is very clear, I brought up HIV, and I highlighted HIV because there's a bit of research that has been done that's identified or tested or looked at proven interventions that address stigma and discrimination in the HIV setting or pertaining to HIV. So we would need to learn from those interventions to apply those interventions in the context of COVID-19, and then take the opportunity in applying those interventions in the context of COVID-19 to actually do the research to do a bit of implementation science research to look at the effectiveness of these interventions in the COVID-19 context in the Caribbean. So how would what are the things that we could do to learn from HIV? This presentation, or this slide here, I really like it because it shows the various levels of stigma within the context of, so you have the internalized stigma that's in the center of the diagram. And then you have the perceived stigma, the enacted stigma, the compounded stigma, and then and the institutionalized stigma. And then you have these different kind of intersections, if you will. So you have, and this is actually a diagram that was developed by the Calgary, or presented at a workshop at the Calgary Sexual Health Center. And it was focusing on sexually transmitted blood infections. And when you look at it, it very much is correlated to the various levels that we need to focus on when we're looking at alleviating stigma and discrimination. So the descriptions of stigma are within the colorful diagram, and along the right side of the diagram, you'll see the different levels of at which stigma may exist and be confronted. So this diagram on the left was developed actually in 2012. However, or in addition to that, there was some work done by UNAIDS in March of this year. I think it was March that the publication date is March. But the UNAIDS formed the global partnership and provided recommendations. And these recommendations are based on evidence from interventions that were developed for HIV. So these areas: community, workplace, education, healthcare, justice, and emergency services, or humanitarian services, are the particular areas where there are interventions that address stigma and discrimination that have been tested and proven to be true for HIV, and are being recommended for use within the context of the COVID-19 pandemic. So the community, I'm going to highlight first the community, the community level interventions. They focus on the general population. So they actually look at individuals, persons who are essential workers, people who have recovered from COVID-19. They look at the families of people. They look at organizations. They focus on even public policy. So for instance, I'm just going to highlight one of the interventions for the individual is actually providing counseling services that also include education. At the policy level for community, it is actually looking at, it's suggesting utilizing, implementing interventions that fund advocacy groups that are led by populations of people who would be at higher risk of experiencing stigma and discrimination. So the workplace in itself, the focus population for the workplace is the individual, employees as groups, and policies within the workplace. So all of these areas would have specific interventions. So I've provided these slides will be available for you, but the presentation will be available for you. But this resource, the UN AIDS brief, Addressing Stigma and Discrimination in COVID-19 Response, will provide the detail. So the brief highlights these following lessons that were learned from HIV. Be aware of stigmatizing language. For example, do not use the words, replace COVID-19 cases or victims with people who have COVID-19. Develop and maintain a human rights approach that pays special attention to vulnerable populations. Don't pass judgment by accusing specific select groups of spreading COVID-19, and ensure policies and procedures are in place to protect jobs and income sources of persons who may experience or have recovered from COVID-19 or experience job fallout from COVID-19. Maintain and respect confidentiality of persons who have had or have COVID-19. And very importantly, engage communities with their consent to increase awareness and educate across the board populations, which is proven to reduce stigma and discrimination. Develop structured and measurable, and I think measurable is the key term, because we need to be able to look at stigma and discrimination and measure how these interventions have positively, or maybe they didn't work, but how they have affected or impacted stigma and the elimination of stigma. And then give COVID-19 a human face. It's good to provide a lot of data, a lot of numbers, but a positive story and with complementary data, with prevention messages, makes a prevention message or any message more memorable. And that's it. So thank you for listening.
Okay, thank you, Dr. Jones. So we've now come to the end of our presentation session. I know we've run a bit over time, but we want to at least take one or two questions. What we'll do is endeavor to send the responses. So if we do not get to answer all your questions today, what we'll do is follow up with a response to you with respect to the questions posed. So I'd like to acknowledge at this time, Corinne Singh-Q. Can you just type your question in the Q&A section? And Jermaine Lawrence as well. You had your hand raised. Also Michelle Hazard as well. So one of our first questions that came from the chat, and this is to Professor Eldemire. Cheryl, what are some elderly care innovations that have come about since COVID? And thus far, how has been the elder care flu vaccine programs?
Thank you very much. The flu vaccine is certainly on our radar, and it arrived in Jamaica only yesterday. So I know that some of us have already picked up ours, and it's being done by both government and the private practitioners. So we're certainly aware of it. The innovation I think that I would mention is the mental health response that has come from the Ministry of Health, with the designation of a psychological first aid responder, where Dr. Earl Wright and the ministry are involved in training the community health aides, as well as the volunteers from the National Council for Senior Citizens, churches, and any community group, to go to the homes, stand at the gate, they're all of the social distancing, etc. Don't want to put any more fear into them, and they will have a program and they will have a response. So there actually has been a response, and a very prompt response, to the issue of trying to support the mental health issues of older people.
Thank you, Prof. Our next question is, it's from Miguel Smith. I believe that the attention given to COVID have overshadowed other serious illnesses that needs even as much attention. Any word of Jamaica getting more support from the international medical community to assist in fighting COVID battle, especially since cases are rising and doctors being reassigned? Anyone wants to take this question? Wants to take that question here?
Well, I mean, as of right now, I don't know of any plans to seek any other international support. I do know that what they're working on is trying to redistribute, the care, so that the burden doesn't fall on any one particular medical team or any one particular hospital right now. But again, things are becoming pretty overwhelming. So I think, again, strategies may have to change again soon. But I haven't heard of any immediate plans on how they plan to do that. Yeah.
All right, thank you for your response. I think we have another question here. And this one, again, is to Dr. Sharp. I believe that the attention given to COVID, I think, yes, you've responded to this question. Sorry. I have another question with respect to the presentations, just to share that the presentations will be shared with everyone at the end of the seminar, the webinar, and we'll also be issuing participant certificates. This session has 1.30 CME credit hours of accreditation. So CME credits will be available for those persons who have attended and participated in the webinar. And so over the next 2 weeks, we'll send via email a copy of your certificate of participation. At this time, I think we'll just take one more question. I think this was addressed, and I think this is for all the panelists. What's your take on vaccination for COVID-19? Anyone wants to respond to this question? This is a question from Michelle Hazard. What is our panelists? I think some of you gave, you shared their views in your presentation, but anyone wants to take this? What's your opinion about the COVID-19 vaccine program?
Well, I certainly hope that we are able to have one or more efficacious and safe vaccines. So perhaps the first thing I would say is that vaccines need to be properly tested before they are used. So the vaccine trials are really important. And the persons who have the most problems with COVID certainly need to be represented in the populations that the vaccines are being tested with. Once there are vaccines that work well, then the high-risk populations hopefully would have access first. And it is really the one thing that I think can really blunt the rapid rise of COVID. We've found that behavioral interventions are very difficult to be maintained. lockdowns are very costly and have lots of impact in various ways, economic, social, mental, and so on. And so really vaccines, once they're adequately tested and they're safe and efficacious, would be a huge step forward.
Okay, thank you. I think I'll do just one more question and then we'll wrap up. We have a question from Bandara Kaur. Is there a place for establishing a mobile unit for providing testing for elderly patients at home for basic blood tests, ECGs, etc., that is subsidized by the government? These services are available privately, but the cost is prohibitive for many patients. I think that's for Prof. Yes.
I think obviously there's a place for it. I'm just not sure that the government at the moment can absorb any additional costs. One of the things that's being taken into consideration and will be built into the mental health program, and they did take on 1,000 extra community health aides, is that we can at least get the blood pressure and the sugar checks done at the home. I think, however, we also, since we do want them to come out even once per week just for some fresh air, as long as they're properly masked, etc., I think that we can also look to the health centers to strengthen. We can look at, can they be a priority? Can they not wait in line? Can they be seen as they come? Can we have a special hour, whether 11 to 12? But I think the point of the question is very important. What other innovative ways can we look at to get this done?
Thank you, Prof. So that's the end of our question and answer session. I'm going to invite all our panelists to just open their cameras at this point in time. And I'm going to invite you just to give us just one or two take-home messages. I'll start with Prof. Eldemire, Cheryl. Yes. Sorry, your mic is muted.
Thank you very much. I think my take-home message is that the COVID prevention measures are extremely vital, extremely important. We've only seen less than 900 cases among our 350,000 older persons. However, we do need to convince our older people that there needs to be a balance and that there has to be some physical activity, and they certainly need their doctors or their health checks, not doctors, because we saw not just doctors, we saw eyes and such. And what I didn't say in the presentation, but came out from the palliative one, we still, even within older people, have special groups. Persons with memory impairment and dementia are really struggling, and we need to recognize this. And they're struggling with the COVID testing when you have to isolate them for 2 days, etc. So I think we can all learn from each other. There's much in all of the other presentations. And thank you very much for this, because I certainly have learned and will now take over some of the other tips into the older person presentations.
Thank you. Prof. Jennifer Knight-Madden.
Thank you, Dr. Davidson. So again, I'd like to stress, as Prof. Eldemire Shearer has, the importance of the basics of the wearing of the mask, washing of hands, physical distancing, and so on. Very important in our sickle cell disease population. For healthcare workers, please remember that the typical presentations of sickle cell disease can also be a presentation of COVID-19, and that this is another time when we have to be very careful with our hemoglobin SC disease, because there is a signal, even though it's early, that they might be at more risk.
Thank you. And Dr. Gilbert Evans.
Yes, it has been said throughout this pandemic that children are the least vulnerable, but this is not true. The secondary impact of the lockdown can have very long-lasting effects on children's nutrition, mental health, and learning. So we need to keep that in mind when we're thinking about the children. Secondly, there is a severe form of the disease that is still largely unknown. And although I have, gathered a bunch of pediatricians to look for it, the studies are showing that it's actually the older adolescents that are more, can be getting it. So the adults need to be aware of the multisystem inflammatory syndrome, and that seeing children is a misnomer because most people don't think of the 19s and the 18s as children, but it can happen in that age group. So I want our viewers to, read up about it, be aware of it, so that when it presents itself, you can intervene. Thank you.
Thanks. Dr. Sharp, thank you. Your mic mute. Can you unmute first, Dr. Sharp? Can you unmute? You're muted.
Okay, got it. Sorry about that. I think what I would most like to say is that with respect to palliative care patients or patients with very advanced diseases, it's important to try and, as much as possible, maintain an open line of communication with, your caregiver, with the medical team. I think that that's what's going to help most to getting to figuring out how to navigate this pandemic, with your cancer care, with your, palliative care.
Thank you, Dr. Sharp. And then we'll have Dr. Jones to take a message for us.
Yes, thank you. I think one of the things I always have to remember is for us to be patient with us. I know that as we wait for this vaccine to help us address this pandemic, we still gonna have to focus on the preventive behaviors that we can manage ourselves. We also have to focus on the fact that there are a large portion of the population that is not receiving the information because of for different reasons we may not understand. But we need to keep pushing information, keep educating, be patient in the education process, share as much information, be as open as possible so that we can reduce these levels of fear and panic to help people understand what's going on and feel better in control of what they can do to prevent themselves or reduce the risk of themselves, their families, their coworkers of contracting the pandemic. I think that's very important across all of the presentations, kind of spoke to that.
Okay, thank you. I think we had a very exciting evening. Thank you for taking your time out to share with us and to join in this today. I think a lot of take-home points today. We certainly learned a lot from the presentations. This will be available on YouTube, so you can go back and review some of these presentations. And we'll also share a copy with participants. And so I'd like to thank you on behalf of CARPHA for coming out for another series of the CARPHA Health Rounds, COVID-19, and we look forward to the next series to take place next week. So stay tuned, walk good, peace, and be safe. Thank you everyone for coming.